Okay, so welcome to the Bay Area Breast Cancer Forum. I'm Hope Rugo, breast medical oncologist at UCSF, and I'm joined by my colleagues, who I'll introduce in just a moment, and Melody Galu, who is the organizer of the Bay Area Breast Cancer Forum, and who you email with getting on lists or for any suggestions, topics, questions that you have about the forum. We usually do the forum every other month and take a break over July and August, and we'll announce our next date very soon. That will happen in the next couple of months. This is a Zoom virtual forum, and if you look at the bottom of your screen, you can see a Q&A button. Please put all of your questions into the Q&A. That allows us to answer them both live and virtually. We try and answer most of your questions live. If you have any trouble with your connection, you can use the chat button, which Melody will be able to answer during the time, or if you want to add your email to the listserv, etc. The Bay Area Breast Cancer Forum also has an address, and we do recordings, and so you can access these recordings. Melody, maybe you can put those into the chat, those links. So the purpose of today and the purpose of the forum overall is to serve you, the listeners, about really to help you understand current and evolving treatments for breast cancer. And we have our fabulous volunteer faculty who take their time in the evening to share with you their knowledge and try and apply it in a way that's both understandable and feels current as well. So the San Antonio Breast Cancer Meeting is our biggest breast cancer meeting of the year. It's attended by an international group of presenters and audience in San Antonio, Texas. Actually, our colleague, Laura Esserman, has been trying to design a different meeting outside of Texas, and that meeting is Rise Up. That meeting will happen the first weekend of November in San Francisco for the first time this year. We also do, presumably we'll do some sort of a update after that meeting as well. San Antonio is at the beginning of December, but we also have ASCO, the American Society of Clinical Oncology, which is in June, and ESMO Breast, the European Society of Medical Oncology, that breast cancer, that meets in May, and then ESMO proper, the European Society of Medical Oncology, which is in September. So there are a lot of different times when new data is updated, which really makes a big difference. Usually what happens is people collect data and then they, ponder over it for a while, have their statisticians go through it and look at it, and they submit an abstract, and then the data is accepted and it's presented. And then updates are presented, and we have a lot of updates as well as some new data to tell you about this evening. But at this meeting, there was kind of a unique thing that happened was that, companies are obliged to put out a press release when brand new data comes out for a clinical trial, and public companies. And so a press release came out about one clinical trial in the metastatic breast cancer setting, hormone receptor positive disease. And the company, Genentech Roche, was convinced to actually turn their data around in 3 days and present it 3 days later at the San Antonio meeting, something that has never happened before. Hopefully we'll have time to share with you that data as well. But I thought that that was really great because it's a way of delivering information to providers and patients in a really rapid way, which is exciting. If you look in the chat, you'll see the link to the breast cancer forum. So it's cancer.ucsf.edu/forum, and you'll find out about lots. And then there's also Bay Area Breast Cancer Forum at ucsf.edu for questions and to join the listserv. So please feel free to share that with your friends, family. This is really open to everybody. So without further ado, we will discuss some of these information. We already have one question in there, which we'll talk about in a little bit. I think we're going to start with early stage breast cancer. And first, Michelle Melisko is going to tell us a little bit, if you're ready, Michelle. Yep. Okay, great. Going to tell us a little bit about cyclin-dependent kinase 4/6 inhibitors for early stage high-risk breast cancer, where we've seen really exciting data over the last few years and have one drug already approved.
Okay, well, we'll go ahead and get started. I'm going to go ahead and share my screen and turn it into the slideshow mode. So welcome, everyone. And so,
So just
just
to introduce, we have Michelle Melisko, who's also a breast cancer oncologist here at UCSF. I forgot the introduction part. And Michael Alvarado, who's our fabulous breast cancer surgeon. And then we'll be joined shortly by Dr. Laura Huppert and Dr. Joe Chien, also our colleagues in breast medical oncology.
So I first, by way of disclosure, I have to mention that Dr. Huppert, who's going to be joining us later, these are, I'm borrowing from slides that she assembled for a Best of San Antonio talk that was given in Berkeley a few weeks ago, I think. And so you'll see these slides again when she presents some of the data that she actually talked about in San Antonio proper. So for those of you who are attending, who many, maybe actually some may be on one of these drugs that I'm going to be talking about, we know that there is, remains an unmet need for patients that have high risk hormone receptor positive HER2 negative breast cancer, where there's, despite our best efforts giving patients chemotherapy and taking, 5 and sometimes 10 years of hormone therapy, that patients still experience recurrence. And so this trial sought to use CDK4/6 inhibitor abemaciclib, also known as Verzenio, in patients with high-risk disease. And for the sake of time, I won't go into great detail, but these in this trial, patients could be pre or postmenopausal, and they had, in many cases, gotten neoadjuvant or adjuvant chemotherapy. And they were randomized to get either a standard endocrine therapy, whatever their oncologist thought was appropriate, either an aromatase inhibitor or tamoxifen, or that therapy plus abemaciclib for 2 years. And this data had previously been presented and led to the FDA approval of this drug, abemaciclib, for high-risk early stage breast cancer. But the update that was presented in San Antonio was to give us an updated efficacy analysis at 5 years, because there's always been some concern that maybe if you give the drug for 2 years, it'll look great for the first 2 years, maybe even out to 3 years, out to 4 years. But then concern is that the curves might come back together and you might lose that benefit. But they presented data showing that out at 5 years, because they first presented it, you can see here on the top, the invasive disease-free survival. The data has been presented a number of times. And in the very beginning, when they first presented it at 2 years, the difference in invasive disease-free survival between the two groups, those in red who got the abemaciclib and those in black who didn't, was 2.8%. And as we extend out further out now to 5 years, the absolute difference in terms of reducing invasive disease recurrences was 7.6%. And then looking down at the bottom of the slide here, this DRFS stands for distant relapse-free survival. So the percentage of women who are alive without the cancer coming back somewhere distantly in their body. And similarly, just as we saw above, the curves did separate, so that in the beginning at 2 years, the difference was 2.5%, and out here at 5 years, the difference was 6.7%. So it's really nice to see that the benefit is not only maintaining, but actually increasing. And they presented some data showing that the safety profile, that longer, term follow-up, they weren't finding any late effects of this therapy. For those of you who have been exposed to this therapy or know that in the short term, it can be difficult to manage in the beginning with some diarrhea, some GI symptoms, but usually that can be pretty well managed with dose reduction. They mentioned that the overall survival data is immature, but they have observed fewer deaths in the abemaciclib plus endocrine therapy arm versus the endocrine therapy only arm. So that was a very nice update. And they did look at some subgroup analysis looking at different subtypes, the luminal A's, the luminal B's, the HER2s, the basals, looking at what they think the oncotype score was. And the important takeaway message was it did seem that across the board, all of these different groups did benefit from the addition of abemaciclib. Even that very small number of patients that are called these basal, these are types of cancers that are ER positive, but they actually behave more like triple negative patients. But moving on to the next study in early stage high risk breast cancer, this was, I think, I wouldn't say more exciting, but we were all very interested in seeing what was going to happen here, was the Natalie trial, which is looking at an alternate CDK4/6 inhibitor, ribociclib, also known as Kisqali. And this patient population, this study population, was a little bit different than the study population in the Monarch E trial, in that it didn't require patients to have positive nodes. Almost all the patients, or if not all the patients in Monarch E, had to be node positive, many with multiple positive nodes. This was a slightly lower risk population. If they were node negative, they had to have grade 2 or greater. They had to have a Ki-67, which is a proliferation rate, so cancer dividing more rapidly, greater than 20%, an oncotype recurrence score of greater than 26. If they had positive nodes, they didn't have to meet those criteria. Another big difference between this trial and the Monarch E study was that patients here could only receive an aromatase inhibitor. Tamoxifen was not allowed as the standard hormonal therapy because there was a problem in interaction between tamoxifen and the ribociclib, which we can talk about a little bit later about ribociclib and how you have to monitor the EKG because it can affect something called the QT interval. The other difference was that patients on this trial received the experimental therapy, the ribociclib, for 3 years rather than 2 years. And so the data had been previously presented with follow-up time of 2 years out here initially, and the invasive disease-free survival difference they saw at that time was 1.8%. And it's very reassuring to see that, just as similar in the Monarch E study, that with longer follow-up, the curves are starting to separate, and the difference is now 3.1% at 3 years. And the distant disease-free survival, they are not actually seeing a difference quite yet. And so you might look at these numbers and say, well, these don't look quite as impressive as the 6 and 7% that we were seeing in the other study population. But remember, this is a much lower, I should say not much lower, but a lower risk patient population. So their just general risk of recurrence is lower than in the Monarch E patient population. So this is exciting news for us because we want to have another drug to offer patients with high risk early stage hormone receptor positive breast cancer. There are patients who can't tolerate abemaciclib because of the GI side effects. And this is a lower risk population. So for example, if we think someone has some high risk features, but has node negative disease, we have a hard time getting approval for abemaciclib because it's not FDA approved in that situation, but this drug hopefully will be. And in terms of overall survival, similar to the Monarch E trial, we need to have longer term follow-up, and there were no new safety signals noted. So I think I can stop there with the summary of these two, Hope. I'm not sure if you have any other things to
Right.
add
No,
for
I
anyone
think that
who knows here.
this is really good, and I think very, very helpful information to hear about. It was interesting. I thought that when the Natalie update, had about 5 more months of follow-up. So the difference from when they'd presented it at ASCO and at San Antonio is very small, but I think it's nice to see that the difference is maintained and not gone away after people have finished drug. I think there were a few interesting questions, of course, that are important for our patients. And one is, what is the optimal duration of CDK4/6 inhibition? We don't have the exact data yet, but a number of patients dropped out from both trials. And it turns out that the most number of patients dropped out in the first 3 months. I think when you finished your adjuvant chemo and surgery, and these patients were higher risk, so a lot of them did have chemotherapy, that sometimes it's hard to go on yet another drug with side effects. And, indeed, patients have fatigue, one of the biggest side effects, and have to monitor their blood counts, et cetera. The most common reason for going off ribociclib was liver enzyme elevations, but that occurred in about 9% of patients. It wasn't so many. But, 2 years of abemaciclib, some diarrhea that you need to manage, or 3 years of another drug with fatigue and other issues. It's hard to know. I wish that we would have some way of knowing. And then I think that, what they did with Natalie was they added a whole bunch of patients, 1,000 patients in the last year of the trial that had higher risk disease because of the results of that first trial that enrolled higher risk patients. So more nodes, more high risk disease. So, but it takes a really long time to see big benefits in patients with lower risk disease because recurrences occur for a long time. So it's going to require some longer follow-up. So one of our colleagues from the East Coast stood up at the conference and said, well, wait a minute, why should patients be getting this drug? Because we don't have survival data yet, and you have all these side effects, it costs a lot of money, et cetera. But, my take on that is that, you can't really have our patients with high-risk disease wait for survival data, because then you're losing valuable time. So I think we've been fairly bullish or pro on this data overall. And then we'll be opening the wider trial, which indeed just enrolls a wider population over more time. That will be patients who have higher risk node negative disease and node positive disease, but can be up to 3 years after diagnosis and still go on ribociclib for free. And it's a non-randomized trial. So, Michelle, what do you think of that? I mean, what is the optimal duration? Would you change anything about what you're doing right now?
Yeah, I mean, I'm for sure not going to be extending, abemaciclib to 3 years. I think most people, limp along and they are so happy to be getting to that 2-year mark, that, very few patients are jumping up and down to take another year. I think the question with the ribociclib is, do we need those 3 years? I would obviously aim for the people that I'm putting on it to aim for 3 years. But I feel like any of these agents, some of it is probably better than none of it, and so I don't think we know, but I'm definitely not going to extend abemaciclib beyond 2 years. But I would be happy. I won't be torturing people if they're really having a hard time with ribo to stay on the whole 3 years. I would shoot for it.
And
I
then,
think that, what
yeah.
Oh, go ahead. I was just going to say that, one of the things that, it is a challenge is having these conversations about which one to pick, because the side effect profiles are so different. And we thought that, that coming in and getting the EKG was going to be, that's sort of what, made us less enthusiastic about ribociclib, in the beginning in the metastatic setting. But now I think we're very comfortable with that. It's no big deal. I haven't seen a lot of QT prolongation, so it's not a big deal. But the blood count suppression and particularly with someone who's been heavily pretreated in the metastatic setting can be problematic. So I think, we have to have a conversation with the patient about what they'd rather, what hassles they'd rather deal with.
Yeah,
It's
I
not an
think,
easy
yeah,
decision.
it's true, because some people really have such a hard time with the diarrhea, and other people have a hard time with other things such as liver enzyme elevations or fatigue. So, for Natalie, they chose, 2/3 of the dose that's approved in the metastatic setting, 400 milligrams. And that clearly was a very, very smart choice, but it doesn't seem to have affected the liver enzyme abnormalities. But thankfully, when you hold the drug, they go back to normal. And essentially all patients, it's just, it's good to have an alternative drug to give in both groups. And just to be clear for our audience, ribociclib isn't approved yet in the early stage setting. We're waiting for the data for Natalie either to be reviewed favorably by the FDA or for a longer follow-up, whatever the FDA requires. Last question, just to Joe Chien, who joined us. Thank you. I previously introduced you. So what do you think about the carryover effect? I think, we were all, I guess for me, that was a little surprising. The fact that there was even more benefit at 5 years, even though people were 3 years off their abema. You're on mute.
On mute.
Sorry, gosh, I can't believe I'm still having problems unmuting. So I think that is really encouraging and not totally surprising, right? I mean, we see the same with hormone therapy, right? You take 5 years of adjuvant hormone therapy and you see the benefit out at 15, 20 years. So I think that further reassures me that this may be a real effect. So I'm very encouraged.
Yeah, I think this has really been such an exciting time to try and improve outcome. We hate these 10-year recurrences from hormone receptor positive breast cancer or any recurrence, and I think being able to move into the node negative group is also really exciting. It's just going to take us a long time to see that impact. But remember, for our audience, the wider trial, which will be opening relatively soon at UCSF, where patients will be able to get ribociclib for free in a non-randomized trial who have relatively less high-risk disease and up to 3 years, I think it's 3 years after finishing their surgery and chemo. So let's move on a little bit. I think this was a great introduction into this really huge advance over the last 3 years now, abemaciclib being approved as of last year. I think earlier this year, the 2023, the approval was broadened not to require specific criteria. But we've also made a lot of improvements in the surgery and radiation area. And it's kind of interesting. I mean, we're trying to both increase treatment in the right settings, like you heard about just now, but we're also trying to decrease treatment as well. And I think we learned some really exciting things about at San Antonio this year on the surgery and radiation side. Michael, do you want to talk about the NSABP trial first?
Yes, sorry. I had a Dr. Chien moment there for a second. Sorry about that. Yeah, let me pull that up right now. I'll share my screen. All right, here we go. So yeah, so there were some amazing actually talks at San Antonio about surgery and radiation and local things. And this next thing that talk that I was going to mention or talk about that Dr. Rugo is talking about has to do with when patients start with a positive node, get the neoadjuvant chemotherapy, and what if they have residual tumor left behind, or what if they don't have residual tumor left behind? So, for example, you had the node positive, and now you've had a complete response. So if you have a mastectomy, do you still need radiation to the chest area and the lymph nodes, even though you had a complete response? And if you had a lumpectomy with breast radiation, do you need to have all the lymph nodes irradiated? And this has been a discussion around the country and around the world about, well, do we base it on what it looked like before the therapy, or do we base it on the response to therapy, which, as you know from all of the other trials, that response to therapy is becoming a much more important predictor or prognostic factor. And we need to start looking at that as opposed to what you start with at the beginning. So this was a presentation from a friend of all of ours, Dr. Terry Maminis, in a big clinical trial called the NSABP B51, which basically looked at that. Women that were node positive, had a lymph node positive before, got their chemotherapy, had surgery, and then had all the tumor cleared in the lymph nodes. And this is a little of a bit of a busy slide, but basically, as you can see here, once they were noted to have, whether they had lumpectomy or mastectomy, if they had a complete response, then they were randomized to no radiation, none of that extra radiation. So for lumpectomy, it was just the breast radiation, and you didn't have to radiate all the lymph nodes. And if it was mastectomy, then there was no radiation whatsoever. So that was one side of the randomization. And the other side was a lot of radiation. So for mastectomy patients, if you had a great reconstruction, they had to radiate that plus all the lymph nodes. And if you had a lumpectomy, they added the radiation as well. And the problem is that, you know, all of that radiation, although it may work well for a lot of instances, it also has a lot of significant side effects to patients, increasing the risk of lymphedema, increasing the chance of a complication with reconstruction. And so a lot of issues. And so really trying to see, can we de-escalate or do less in these situations? And the objectives were to look at what's the chance of it coming back in that chest area? What's the chance of it showing up deeper in the body? How about overall survival and toxicity? And it was a pretty big trial, about almost 1,600 patients, and a pretty good follow-up of about 5 years. And you can kind of see here, this is just a little bit of kind of the demographics, the age of the patients. A fair amount of them were in the younger, less than 55 category. Also, you can see this down here is the tumor size. So there was 2 to 5 centimeter tumors was the most common. So these weren't tiny little tumors or tiny little things. So these were kind of the things that we see all the time. With regards to the biology of these patients, you can see that that there was a good spread between the estrogen positive, the estrogen negative, the HER2 or HER2 positive, and things like that. And basically what we see here, which is great for women, is that these are the curves or the kind of showing what happens over time, and the red line and the blue line, as you can see, basically overlap each other. So there was no difference, meaning that doing less radiation was not dangerous. There was no increased risk of any recurrences, and really wonderful for these patients, especially decreasing the chance of lymphedema with all the radiation, decreasing the chance of causing problems with the reconstructed breast, for example, as well. Really just looking at, well, Is it going to increase the risk of something coming back right in the breast or right in the armpit, the lymph node area? And statistically speaking, there was no difference, which is great. Again, things that really, really important is we don't want to do anything that increases the chance of something showing up deeper in the body. And as you can see here, those red and blue lines are perfectly overlapping, so there's no difference there as well. And again, overall survival, no change as well. So, and then with regards to toxicity, although there's small percentages, but you can see that if you get all the radiation over here, there is a higher chance of having problems with toxicity. So again, less toxic, but great outcomes, and there's no increased risk for these patients. So the conclusions were that these findings suggest that by downstaging the lymph nodes with the neoadjuvant chemotherapy, you can optimize the adjuvant radiotherapy by doing less without affecting the oncologic or, you know, the cancer outcomes that we're looking for. And of course, they're going to follow this up for longer outcomes, but I think most of us realize that for these higher risk patients that are getting chemotherapy before surgery, most of those recurrences are going to happen early. And so this is very good information to help us do less for these patients. And so I think that was a great publication. And as Dr. Melisko, Dr. Rugo, Dr. Chien, and Dr. Huppert know, at UCSF, we've been, you know, selectively identifying patients like this for a number of years based on data that has been out there from single institutions and things like that. And, you know, because we felt very, very good about that, and, you know, and within the neoadjuvant setting that these oncologists have been championing for years now with the I-SPY data, showing that we have excellent outcomes when they have complete responses. We've been doing that for a while. This backs up what we've been doing, and now is going to open it up even in more places across the country, hopefully for patients to do less. So that's kind of what I wanted to show for that one.
That's really great. And we have some other really exciting areas that Mike will talk about in a little bit, but let me just ask you a couple of questions that came in. You put in the paper about intraoperative radiation, which I think is really nice, into the Q&A, and everybody can look up answers to the Q&A yourselves by clicking the answer section. But who is eligible for intraoperative radiation therapy? When should we recommend it?
Yeah, sure. So going to a completely different type of patient than what we were just talking about, obviously, but mostly it's going to be for women that are postmenopausal, that have tumors that are about 2 centimeters or less, estrogen positive, the HER2 or HER2 negative, lymph node negative, grade 1 or grade 2. So more of the unlikely to get chemotherapy, more always going to surgery first type of patient. And it's showed very, very good outcomes. There is a slight increased risk of a local recurrence, about a 1% difference. So at 5 years, it was 2% for intraoperative radiation therapy versus 1% for the standard radiation. But when you look at the longer term follow-up, the chance of being alive at 12 years with no recurrence in the breast was the same on both sides. So I think it's a great option for women. And the wonderful thing about radiation oncology now is they're finally starting to do more risk-adapted therapy, similar to what the oncology people have been doing for a number of years now. Sometimes we talk about radiation oncology as the final frontier for please de-escalate whenever possible. But now they're realizing that there's so many options. There's potentially no radiation for tiny, tiny, tiny little tumors in women over the age of 65 or 70. There's a one-time dose for tumors. There is, 5 days of radiation. There are a lot of different types for women, and it's important that they understand that they should try to ask those questions about, the different options that they might have.
Yeah, it's so important, because you hate to see somebody now who has a full node dissection who doesn't need one, or even goes back to have a lot of nodes who might not need it. So we'll talk about that more later, but I think the intraoperative radiation is a really select group of patients. And Michael actually did some of the very first work in this area, so he's a fabulous person to answer that question. There was also one question about breath holding on the left side. does it work? We definitely do. I mean, there's a lot of interest in that, right?
Yeah, no, for sure. I think it does help. And there's also other techniques that they use besides breath hold for left-sided breast cancers and special, modulated radiation therapy, the so-called IMRT radiation, and the planning. And so they've really been able to avoid radiation to the heart, even for left-sided breast cancers. There was, certain places around the country push for what's called prone radiation, so laying face down to have the breast hang away from the body to maybe decrease the heart dose. That was really championed at NYU, New York University institution. But there are just a lot of great ways to avoid radiation to the heart, and especially now with the option of potentially doing even partial breast irradiation in the external beam field. So, just focusing on where the tumor was and avoiding the whole breast, and then avoiding even more the heart and the lungs.
Yeah, so definitely bring up these questions if you have them for your radiation oncologist, but it's also important to keep in mind, a lot of the patients, for example, that I see, that we see that are getting neoadjuvant therapy have really more extensive cancer and may not be eligible for those more limited field radiation, although certainly other techniques can be used in the left side. So now, so let's go on. We'll come back to Michael and to others, but maybe what we'll do is talk a little bit about fertility preservation. There was a really interesting trial called the Positive trial. We saw a little bit more update about at San Antonio, and a whole bunch of other studies, which we won't have time to talk about, kind of a series of like everybody in fertility, but it's really, I think, practice changing and important, unique work. Joe, tell us a little bit about that.
Thanks, Hope. Yeah, so as we all know, breast cancer is difficult for all patients, but there are some unique challenges for our young patients in particular. Amongst those challenges is fertility. Many young women feel that their ability to have children after breast cancer diagnosis is compromised. And that's for many reasons, because of the chemotherapy and affecting ovarian reserve, the need to be on hormone therapy for at least 5 years, right? And many patients that would put them sort of into their mid-40s. And then just the fear of recurrence. So I'm going to share some slides. Hold on one sec. Okay, can everyone see this?
Yep.
Okay, so this is the study that I'm going to present. The Positive study, the purpose of this, the primary purpose of this study was to really look at the safety of interrupting hormone therapy within the first 5 years in order to attempt pregnancy. And the primary outcome of this study was to look at the chance of having a breast cancer recurrence in patients who took a break from their hormone therapy to get pregnant, and those and compared that risk to what we call a historical control from patients in a different study who did not get pregnant. Okay, so obviously this was not a randomized study. We can't randomize patients to pregnancy or no pregnancy, but the main purpose is to look at the risk of recurrence in patients who took a break from their hormone therapy in the first 5 years to get pregnant. They already reported the chance of recurrence previously, and now it's published. And here is the study design, just so, hold on, let me close this. Sorry. Okay, so here's the study design. It enrolled patients who are under 42 years of age. They must have had at least 18 months of adjuvant hormone therapy, so 18 to 30 months. And then at that point, they can stop their hormone therapy. There's a 3-month washout. And then they are given up to 2 years break off of their hormone therapy in order to conceive, deliver, and breastfeed if they wish. And then the expectation is that they would resume their hormone therapy after delivery in order to complete the 5 to 10 years or whatever their oncologists recommended, and they were followed for a number of outcomes. The primary outcome was to look at breast cancer recurrence, but they also wanted to look at pregnancy outcomes. And so previously, they reported the breast cancer outcome and showed that with just 3 years follow-up, the risk of a recurrence was 8.9%. And they compared that to a similar population of young women in a different trial called the Soft and Text trial. And these women did not stop their hormone therapy to get pregnant, and then looked at their rate of recurrence at 3 years, and that was 9.2%. So the conclusion from that primary report was that the recurrence risk was not different, not worse, in patients who took the break off hormone therapy in the first 5 years compared to this control. The caveat is that these were relatively lower risk patients, not a lot of stage 3s, and the follow-up is still pretty short at 3 years. So obviously we want to look beyond that to see if that continues to be the case. But what's new about the San Antonio presentation is that they reported on the fertility outcomes, which we're all very interested in as well. And this was in a total of 516 patients. What they found was that in the first 6, so all 53% of patients at the time that they started the study were what we call amenorrheic. They were not having periods, okay? And that's probably due to the treatment. So when they come off their treatment, what they found was that the majority of these patients recovered their periods. So 94% of them recovered their periods by 6 months. So that's good. These are premenopausal women. What they found in terms of the chances of pregnancy, the number one predictive factor is the age of the patient. And that's not entirely surprising. And what this shows is that if you look on the x-axis in the horizontal line, this is the time, the months since enrollment, and the y-axis is looking at the cumulative incidence of pregnancy, the percentage of patients that got pregnant. And you can see that the green line, which are patients who are under 35, at the 2-year mark, 80% of them had at least one pregnancy. The red dotted line is patients who are 40 to 42 at the time of enrollment, and 50% of them reported at least one pregnancy. So lower in older patients, and then 35 to 39 where it was in the middle. They also looked at patients who used assisted reproductive technology like egg harvesting, IVF, and found that those who used assisted reproductive technology did not have any higher risk of recurrence at the 24-month mark on trial compared to those who did not use assisted reproductive technology. And they also saw that patients who harvested eggs at any time point, there was no increased risk of recurrence at the 3-year time point. So to summarize the new data from San Antonio from the positive study, greater than 90% of women presenting with amenorrhea, meaning not menstruating at the time of enrollment, not greater than 90% of them resumed periods, most during the first 6 months. Young age was the main factor associated with shorter time to pregnancy. Assisted reproductive technologies such as embryo or egg freezing at the time of diagnosis, followed by embryo transfer after endocrine therapy interruption, had higher rates of pregnancy and was not associated with worse prognosis compared to those who did not use assisted reproductive technology. There was no increased risk in patients who used IVF, although we do need longer follow-up, as they only looked at 3 years follow-up. And so these are really important data. They're unique data. These are data that are very difficult to acquire. And it really provides at least some data to help inform our patients on the risk of trying to get pregnant, which is incredibly important to our young patients. And at least based on these preliminary data, it looks like that it can be safe for some women, with the caveat that these were relatively lower risk and we have short follow-up, so we need longer follow-up.
Yeah, that's so interesting, Joe. Thanks for sharing that data. And in another presentation, it didn't appear that there was any difference in patients who had BRCA germline mutations either. So that was kind of encouraging. What is your take-home message for your clinical patients? How does, for example, stage, use of CDK4/6 inhibitors, et cetera, influence your recommendation, and age too? Because we do see women who are diagnosed at 38 and are just going to be, 40 after 40 years or older by the time they get to this time point.
Yeah. I mean, first, I'll just say this is such an individual discussion and very personal to each patient. And there's so many factors that are personal and individual. But I will say that the patients who have higher risk, meaning the patients who probably are on the CDK4/6 inhibitors, right? These are patients who have node-positive disease. I think the current data, the data I just showed, it didn't have enough of those patients in the study for us to know for certain that there isn't some increased risk from interrupting hormone therapy. I always say that, as an oncologist, if I were a purist and I was just coming, having a discussion as an oncologist and not as a human, I would say, of course, I would prefer for you to finish your 5 years of hormone therapy. Of course, for a high-risk patient, I would prefer for you to finish your 10 years of hormone therapy. But that's not realistic. That's not, aligned and consistent with many and most of our patients. And so it's very individual based on their underlying risk and how old they are, and really how old they, we did a survey. We have a young women's registry where we asked patients, what is too old for, do you consider too old to have a child? And it's very interesting. It's very different. And it may be that for, a 32-year-old, 35 is too old, right? And so it's so individual, but the take home is it has to be an individualized discussion based on the breast cancer risk and their personal situation.
Yeah, actually, Joe and colleagues have done some very nice work with these surveys and are moving now into patients who have more advanced disease. But Joe just was recently published this data in one of our journals, and I think really important because what was amusing actually and kind of sad was that one of the reviewers said, well, at UCSF, you could do that, but you're not doing that other places. But actually, this shouldn't be the case. Everybody should have access to fertility preservation techniques, and to a discussion about this. It's recommended by our international guidelines, and there are always places to go to. And, we have a fertility expert team who are on speed dial, so that when someone gets diagnosed, we're able to send them in and do harvesting within a couple of weeks. So that helps. And also, I think that we do have that bias about extending treatment, but having hard data like this is so important to benefit our patients. So really great to hear about that. We, again, we talk about more and less all along the time. And one of the things that was studied in patients who have more high risk hormone receptor positive breast cancer was whether or not, like triple negative breast cancer, we should add immunotherapy to our neoadjuvant treatment. So when we do give patients chemotherapy before surgery for hormone receptor positive disease, is there a group of patients who will benefit from immunotherapy? And this was a really sticky topic because most hormone receptor positive cancers that we see in older women are slow growing and don't have any sort of immune activity. So this is really selecting out a very unique group of high-risk cancers. And Laura Huppert actually did some work in our I-SPY 2 trial and had already shown that there's a group of patients who might benefit. And then we saw a big data sets, and Laura will tell us a little bit about that. Still early, but very interesting.
Wonderful. Thank you so much, and wonderful to be here tonight. Let me go ahead and share my screen.
So as I introduced earlier, Dr. Laura Huppert from our breast oncology program.
Great. Can you see that, Hope?
Yep.
Perfect. It's great. So as Hope mentioned, one major question is, we previously have seen data showing that immunotherapy really helps patients with early stage and actually metastatic triple negative breast cancer. But the question is, should we use immunotherapy for patients with high risk hormone receptor positive HER2 negative early stage breast cancer, and in particular, those more aggressive hormone receptor positive HER2 negative types? And so there have been two recent trials initially presented at ESMO in Europe in this fall. And then there were updates on biomarkers presented at San Antonio. And so I'll kind of walk through those data. So the first trial is a trial called Keynote 756. And this trial enrolled over 1,200 patients that had typically stage 2 and stage 3, so early stage hormone receptor positive, HER2 negative disease. They had to have grade 3 biology, so faster growing cancer. Most of the patients were node positive, or they could have a large tumor that was node negative. They had to be treatment naive, so not having received treatment yet. And they were randomized to receive 1-to-1 to receive chemotherapy alone with placebo before surgery, or chemotherapy plus pembrolizumab, which is an immune agent, immunotherapy. And the idea of immunotherapy, broadly speaking, is we know there are some tumors that are more responsive to immune agents. And if we can rev up the body's own immune system, it could potentially help fight the cancer better, which we've seen for triple negative breast cancer. And so this trial was basically designed chemo alone or chemo plus immunotherapy, which one is better? And they got these therapies before surgery in the neoadjuvant setting. Then they went to surgery. And then if you were randomized to receive the pembro up front, you continued the pembrolizumab immune therapy afterwards with endocrine therapy. Or if you got the placebo, you'd get placebo with endocrine therapy. And they looked at both PCR rate, meaning what is the rate that there was no tumor left in the breast or the lymph node. That's called a pathologic complete response. That was one of the primary endpoints. And then the second primary endpoint is something called EFS, event-free survival, or what are the, what's the risk that we'll have a recurrence, either metastatic or local recurrence in the future. And so the first data always to present is the PCR data. What are the responses at surgery? And that was what we saw first. There was a very similar trial, looking through these, there we go, called Checkmate 7FL, which similarly looked at high-risk hormone receptor positive HER2 negative cases, had to have grade 3 or faster growing tumor biology. But in this case, he still got chemotherapy before surgery with or without a different immunotherapy agent, this time called nivolumab, went to surgery, got it afterwards. A very similar design. In this slide, I sort of compare the two trials side by side. Both phase 3 trials, they're very similar, both placebo-controlled trials. They used different PD-1 inhibitors. So like I said, the first trial used the drug pembrolizumab, the other trial used nivolumab. The Keynote 756 trial was a bigger trial. Overall, they enrolled a very similar group of patients. They had to be high-risk hormone receptor positive with grade 3 biology, so faster growing tumors. There were slight differences in enrollment criteria as shown. But both of the trials looked at a primary endpoint of PCR or pathologic complete response. So was there tumor left at the time of surgery? But only this first trial was powered to look at EFS or event-free survival due to statistical differences and changes in the initial design of the second trial, which we don't need to get into today. But in terms of looking at the PCR data, so these were the two trials that were presented at ESMO. And the Keynote 756 trial with the pembrolizumab shown at left. And you can see the group that got chemo plus pembrolizumab is in turquoise, and chemo plus placebo is in this maroon color. And as you can see, the patients that received the pembrolizumab had a higher PCR rate, a 24.3% PCR rate, so no tumor left in breast or lymph nodes, versus a 15.6% in the placebo group, so a difference there of 8.5%, suggesting that adding pembrolizumab improved PCR or getting rid of the tumor in breast and lymph node. Very similarly, in the Checkmate 7FL study, you can see the difference there was 24.5 with the nivolumab versus 13.8 with placebo, so a difference of 10.5%. So actually remarkably similar numbers and differences between the two trials, which is reassuring. At San Antonio, we also saw some subgroup analyses by biomarkers. So can we pick out basically, are there certain features of different patients that will predict people are more or less likely to respond to these agents? And in the Keynote 756 trial, the trial with pembrolizumab, they showed that both stage 2 and stage 3 patients, so whether or not they had more involvement, they both seemed to benefit from the pembrolizumab. In particular, the patients that had node positive disease, so cancer in the lymph nodes at the time of their initial staging, seemed to benefit. There were a fewer number of patients that were node negative, but the benefit was less clear. And then they also looked at different biomarkers. So we know there's different markers basically on the tumor that can tell us a little bit about how immunogenic a tumor is. And one of these markers is called PD-L1. They look at it by this assay called 22C3-CPS. And they looked at across the trial what their score was. And as you can see, those that had a CPS score that was low, less than 1%, the benefit, both groups, actually the pembrolizumab and the control group had lower rates of PCR, and the difference between the groups was only 4.5%. But as that number got higher with increasing CPS scores, actually both the control and the pembrolizumab group had higher PCR rates. And as you can see, the difference was even greater between arms, suggesting that those with higher CPS scores are more likely to get PCRs in general, and in particular seem to benefit even more from the addition of the immunotherapy drug. They also looked at it by ER percentage. So we know amongst ER positive tumors, you can have a tumor that's ER 90% positive, or you can have a tumor that's ER 5% positive, in various different numbers. In particular, those patients that had very low ER between, 1 and 10%, in general, they had a higher PCR rate, and the benefit of adding pembro was a larger, versus with higher ER percentage greater than or equal to 10%. There was still a benefit with pembro, as you can see here, but the percentage was smaller. So this sort of makes sense. The low ER percents are almost triple negative like. We know that triple negative tumors in general have higher rates of response, and that pembro helps these patients. So it's sort of not surprising that with these very low ER percentages, we're seeing more benefit there. In the Checkmate 7FL trial, actually very similar data, which again sort of is reassuring that, across 2 different trials, 2 different patient groups, the results are actually very similar. So they also looked by PD-L1 score. And as you can see, they used 2 different assays for PD-L1 in this trial, which was different than the last, but bottom line is low PD-L1 score. The benefit was less impressive, but with increasing PD-L1 scores, there was an even greater benefit of adding the immunotherapy drug. This is very similarly with low ER percentage, higher PCR rates overall, and in particular, a more benefit with adding the nivolumab. With as ER got higher, the benefit was a little bit less clear. Similarly, low PR, more benefit, with higher PR, less clear. They looked at something called tumor infiltrating lymphocytes, or TILs, and those that had more TILs had more nivolumab benefit as well. And there was no difference by something called Ki-67. Whenever we talk about adding a new drug, potentially this can help some of our patients. What are the downsides? What are the side effects? Treatment-related side effects were reported, and I just show it here for the pembrolizumab trial, Keynote 756. Immunotherapy, the idea is to rev up the immune system to help fight cancer. Unfortunately, you can also have autoimmune side effects where rather than fighting the cancer, it can fight self. And so things like rash, thyroid abnormalities, low cortisol from your adrenal glands, elevated liver tests, and then more rarely things like heart, lung, neurologic problems. So you can see here with the immune drug, slightly higher rates of some of these autoimmune side effects. This slide only shows in general, but autoimmune side effects were slightly higher with the pembrolizumab agent. And so takeaways from these 2 trials, Keynote 756 and Checkmate 7FL both showed that adding immunotherapy in these high-risk hormone receptor positive patients improved PCR rates. And in particular, it seemed to be that patients who are PD-L1 positive and those that had low ER and low PR seemed to benefit the most. I think, is this changing practice right now? I think not quite yet. I said there's 2 endpoints for these trials looking at, what is the PCR rate? Does it actually help you get less tumor at time of surgery? What we really care about, though, is, what are recurrence rates and long-term outcomes? And so we don't yet have those data, and it'll take us, a couple of years to see those, events and data come back. So as of right now, immunotherapy is not yet approved, and we wouldn't use it yet. I think the one group of patients where, based on this data, I would consider adding immunotherapy is those very low ERs that are almost triple negative. We've always sort of wanted to treat them like triple negatives, and I think this data sort of suggests that we should, and we should add immunotherapy even with this early PCR data for those group. But I think for those with higher ER percentages, I think for most patients, we should wait to see the long-term data to know for sure. But I think very likely, we'll hopefully see that data, and it hopefully will be approved in the future for some patients if the event-free survival data also goes along with the PCR data and shows benefit. And then we'll also need to see whether we can use these biomarkers to help us choose. Like I said, the higher PD-L1 seem to benefit the most. Will it end up that those are the only patients that should get it, and we shouldn't give it to the low PD-L1? I think we need to see what the long-term data looks like there as well. With the ultimate goal to try to, help as many patients as we can with these drugs, but also not to give it to the patients that don't need it, that won't benefit, given the downsides with the toxicity. And so trying to individualize care as much as possible. So I think bottom line, really 2 exciting trials. I think likely we hopefully will see one or both of these agents approved in the future based on these data, but we need a little bit longer follow-up. But I think hopefully this will help patients like this in the future.
Yeah, so that was great and really interesting. And of course, as I mentioned, Laura had actually worked on looking at a group of patients in I-SPY 2, our neoadjuvant trial, who had high-risk disease by our gene expression test MammaPrint. And there was a group of patients there who really seemed to benefit, although small numbers compared to this, from immunotherapy. So it already gave us an idea. And now looking at all of the combined analysis more recently by our colleague Denise Wolf, it further shows that by the markers that we use in I-SPY 2, we already have been selecting patients who are most likely to benefit from immunotherapy. So that's kind of exciting because, sometimes we see immune toxicity, so we want to be careful that we're giving these treatments to the right group of patients. And it does appear that we were doing that even long before this data came out. But I think the FDA has also been very clear that they will not approve anything based on PCR alone. So the response alone, they want to see that people don't have recurrences, as Laura mentioned, event-free survival. So we're going to have to see that data before we get approval for immunotherapy. I have one patient where I did get compassionate use immunotherapy for who had a very high PD-L1 score, so a really high immune marker, and ER positive, not the low ER, but big, huge inflammatory, terrible cancer with a lot of nodes and everything. And she's had a beautiful response. It's just because it was so PD-L1 positive, it seemed hard not to give her that opportunity. So we have been giving her immunotherapy, for better or worse, a little bit past where the standard is, but sometimes we do that. I think we have to. So that was a really nice presentation. And definitely, I think that one question I think that came in the Q&A, and thanks for asking that, is why low TILs would be a biomarker, but I think you meant that high TILs are.
Oh, yes. If I said low,
yeah.
I meant high. High TILs are a biomarker for immunotherapy benefit.
So high TILs correlate with PD-L1 and have correlated with more immune responsive tumors, both in the early and metastatic setting. And there's definitely been a cutoff with actually prognosis with TILs, even in patients with early stage breast cancer, and long now ago published data. So hopefully that answers your question. I think they saw actually a very low cutoff for benefit of TILs in the 7FL trial. Really exciting is that hopefully we'll be able to work with 1 or 2 of these groups and look at the gene expression test that was developed by our very own UCSF I-SPY laboratory colleagues, looking at something called Imprint, which is now being done by Agendia, the same people who do MammaPrint, where we might be able to predict which patients benefit by a simple gene expression test without counting tumor infiltrating lymphocytes, et cetera. But we're even looking at PD-L1. I mean, this might be a better predictor. So hopefully that'll be sometime in the next couple of years where we'll see that as well. So thanks, that was great and really interesting. And I think, sort of a work in the future. One of the questions that came up, Michelle, was whether there was any new data about TrueCap. So capivasertib, there's been a lot going on in the metastatic setting about hormone therapy. We have, of course, a new oral endocrine therapy called a selective estrogen receptor downregulator, elacestrant, but we also have a new targeted agents like capivasertib from the Capitello 291 trial and are doing another trial that I know you're going to mention. There are new trials with other oral endocrine agents that we're participating in and have open for our patients. And then, of course, we saw some final data with the CDK4/6 inhibitor abemaciclib too. I know it's a big task, but maybe you could summarize some of that data for us, Michelle.
Okay, well, we can start with, I want to make sure you have time to talk about your presentation as well. So we can just quickly go into the capivasertib. It's taken me a long time to be able to actually say that. So this is one of the cases I probably will use TrueCap more often than the generic name. So this is, again, I'm going to share my the screen. This was, again, these slides taken from the presentation that was at the Best of San Antonio. And this came from a poster, so I apologize that it's kind of small, but the Capitello 291 study was a randomized phase 3 clinical trial that was looking at patients with advanced metastatic breast cancer, hormone receptor positive, and HER2 negative. And they were selecting patients that I didn't mean to do that. I'm going to go back. They were selecting patients that had recurred within 12 months of completing their adjuvant aromatase inhibitor or had progressed while on an aromatase inhibitor for metastatic breast cancer. Patients were limited to receive no more than 2 lines of endocrine therapy in the metastatic setting and no more than 1 line of chemotherapy. And they wanted to select a patient population that had mostly received a CDK4/6 inhibitor. So their goal was to have at least 51% of the patients enrolled having received a CDK4/6 inhibitor in the metastatic setting. Patients couldn't have received prior therapy that targeted the mTOR or the PI3 kinase pathway, so something like alpelisib or Afinitor, these drugs that are already approved for this. And because this class of drugs, the mTOR inhibitors, the PI3 kinase inhibitors are known to have an impact on blood sugar, they did not want to enroll patients that had elevated hemoglobin A1C. So this is a big problem with this whole class of drugs, is management of hyperglycemia. And so patients were randomized to receive fulvestrant, so Faslodex, to receive that or a placebo or capivasertib. And this is an oral therapy given in a somewhat, unconventional way. We're becoming more familiar with this kind of dosing strategy of receiving the drug 4 days and 4 days of the week and 3 days off. So many of our other drugs we're, very familiar with the 14 days on, 7 days off, or 21 days on, 7 days off. But, this is now, I think, the first approved drug in breast cancer where it's given 4 days on and 3 days off. And the endpoints we're looking at progression-free survival, both in the overall patient population and then patients specifically that had alterations in this AKT pathway, which could include a PI3 kinase mutation, an AKT mutation, or a PTEN mutation. And so over here on the bottom of the screen, I know this is quite small, they looked at the outcomes in the global population. And then in the update that was presented at this meeting, which is what I wanted to focus on for the sake of time, was looking at the outcomes in patients that had particular mutations. So PI3 kinase alterations only, AKT alterations only, or PTEN. And in fact, it looked like the patients that had AKT and PTEN alterations had a more impressive progression-free survival than those with PI3 kinase mutations only. So 9.1 months for patients that had an AKT mutation when they received capivasertib with fulvestrant versus only 3.7 months for those who received fulvestrant alone. And that was similar in the PTEN population, not quite as impressive in the PI3 kinase mutated population. And so I'm going to just go back to this. And so they made the point that the FDA approved capivasertib in November of 2023 for this AKT mutated population that could include PI3 kinase, AKT, and PTEN in patients that had progression on at least 1 line of endocrine therapy. They really found that if you didn't have one of these mutations, that when they looked at the biomarkers, that the standard global population, they didn't really have a significant improvement in progression-free survival if you did not carry one of these mutations. So BICR stands for Blinded Investigator Review. And so basically they deemed that the biomarker positive, or those patients that had those mutations, drove all of the overall benefit. So that's what drove the FDA to only approve the drug in these mutations. So now just, globally thinking about our breast cancer choices that we have now, the mTOR inhibitor, Afinitor, was the first approved. It's been approved now for over 10 years. And it took us some time to become familiar with how to manage the toxicities of that drug, with a lot of mouth sores. And thanks to work that was done by Hope and a trial that we had open, we've kind of got that covered now. We know that if we give patients steroid mouthwash, we can really manage the mouth sores for an mTOR inhibitor. With the first FDA-approved PI3 kinase inhibitor in breast cancer, alpelisib, I think we still do struggle with the side effects of hyperglycemia and rash. And then all of these drugs across the board do have a small risk of pneumonitis, or inflammation in the lung, with it being probably most pronounced with Afinitor. So we're learning how to manage the side effects of these. And I think it's a, really interesting conversation we could have if we had a lot of time to talk about, how will we choose? For me, I think this data was quite interesting because it really does say if you have that rare patient that has an AKT mutation, more than not a PI3 kinase mutation, but an AKT mutation, this really does appear to be the right drug. Same thing for a patient that has a PTEN alteration. So where is this going? Well, in the next, step is to look at what about giving this drug in combination with a CDK4/6 inhibitor to see if we can actually prevent resistance. So the Capitello trial, the 292 trial, which we actually have open at UCSF, will be randomizing patients, actually we'll be giving patients, not randomizing patients, giving patients the combination of this fulvestrant with capivasertib, and in the case, the CDK4/6 inhibitor is palbociclib. And there is a number of, it's a dose finding study, so we're going to be testing, how much of these various drugs can we give together, and the hope is that we would be able to prolong the time to progression that we already, it's already very, very good with fulvestrant and palbociclib, but hoping we can make it even better, maybe pushing it out to a limit where patients might get, over 2 and maybe even 3 years of stability with their first line of endocrine therapy in the metastatic setting. So that's, kind of exciting. I'm excited to use this drug. I haven't had the opportunity to give it very often yet, so I'm really excited to have, a patient come along with an AKT mutation that I can use it.
Yeah, that's great. That was a really nice summary, Michelle, of that data. I think that, you don't have to have an AKT mutation, right? So anything in the PI3
family,
kinase
right.
pathway, 3TA, AKT, PTEN loss. It's interesting because there were, there's really small numbers in the AKT inhibition and PTEN loss, but no real difference, as you showed, in terms of what the benefit was in that group of patients. And so that I thought was really nice to see in that analysis. And in fact, the Capitello 292 trial now will randomize patients. So you either get the CDK4/6 inhibitor with fulvestrant, with or without capi, because it's a first line approach. And I think that that's exciting because the ribociclib arm will also open soon too. I'm not exactly sure when, but I think that will be good in the next short bit. I think we'll be able to also treat patients there. But they have selected a specific group of patients for that trial, which are patients who relapse within a year of finishing their adjuvant endocrine therapy. And I think that that's a group of patients where preclinical data in a mouse model showed that triplet therapy was particularly effective. And so that's actually a very exciting area. And I'm just going to, before we talk about sentinel nodes again, I'm just going to very briefly talk about that study that was presented that where it was 2 days after the press release. And there was a question in the chat about why Palbo in the Capitello trial, and it really just was that Palbo mixes with everything really well. and the other drugs don't as well. So it's just more of a challenge, but the ribo will be a choice. You'll have a physician's choice of these different agents, ribo or abema. It's just that it takes a little while to get the safety data put together, and palbo was first. And P10 loss is assessed by, in the Capitello 291 trial, it was assessed by tissue, but correlated with plasma circulating tumor DNA, so just a blood draw. But P10 itself testing isn't validated well on ctDNA, so there's a lot of work going on with that right now. So it can be done on either, and the drug is approved based on either, so that's all good. Hopefully those were adequately answered questions. So I think that we saw, it's exciting to have a new drug available, but again, there are patients whose cancers recur very early in the course of their treatment. So, and the definition, let's see if I can, there, you can see my screen. The definition of primary or secondary endocrine resistance by our international groups has been patients whose cancers recur within a year or while on treatment given for early stage breast cancer. So, for example, if you had your surgery and you started on endocrine therapy, and then your cancer came back as metastatic disease, either within a year of stopping or while on treatment, that would be this endocrine resistance. If it occurs within the first 2 years of treatment, that's primary endocrine resistance. Now, all of these terms are changing now because of the use of CDK4/6 inhibitors, but the data that I mentioned that was presented at San Antonio is here, and we're hopeful that this will result in approval of this combination sometime by the end of this year. It takes a little while. The trial is called INAVO 120, and it randomized patients who had this definition of primary or secondary endocrine resistance and also had a mutation in PI3 kinase called PIK3CA. It could have been by blood, so-called circulating tumor DNA, or by tissue. Most of the patients had ctDNA done. They also could not have diabetes. So that's because drugs in this class, like the drug alpelisib, all cause, and these inavolisib doesn't have a name yet, right? But the alpelisib does as Piqray, but they have to get to be close to market to have a branded name. So inavolisib doesn't yet. But we know this whole class of drugs, capivasertib much less so, because it's an AKT inhibitor, but the drugs that are PI3 kinase inhibitors, they cause diabetes, they can cause high sugar. So patients who already have a high sugar are at much higher risk. So in this, you could have had a little bit of high sugar, but not much. Most of the patients did not have any evidence of glucose intolerance. 325 patients were randomized to get the standard treatment, which is fulvestrant and a CDK4/6 inhibitor. In this case, it was palbociclib, and a placebo, or the same combination with inavolisib that's given continuously and daily. So the patients, they had an interesting group of patients, and 38% of the patients were from Asia, which is interesting. They had a big enrollment of patients who were treated in Asia, and that may be why a lot of patients received tamoxifen. So that's at the bottom here, 50% had received adjuvant tamoxifen, whereas I think among my colleagues and myself, for younger women with higher risk cancers, we tend to use aromatase inhibitors and ovarian function suppression in the 40% of patients who are premenopausal in this group. But a lot of them had disease in their lungs or liver, about 82%, 80% across both arms. So this were patients who had a lot of cancer. And there has been other data recently presented that showed that patients who have this rapid recurrence with a lot of cancer have a short time of disease control getting fulvestrant and a CDK4/6 inhibitor, mostly palbociclib. So what they saw was this remarkable data. So if you look right at the beginning of the curve here, where it starts from 100 and starts to go down, what you're looking at here are patients in the blue line who received inavolisib, in the red line who received the standard combination, so triplet, doublet. The line here falling down represents how many patients' cancers have not grown. So you're really looking what's called progression-free survival. So the time until the cancer starts to grow by imaging or other ways of evaluating the cancer, usually by scans. What we see in the beginning is a big drop-off in patients who have endocrine-resistant disease. What you can see is that drop-off occurs only in the patients who didn't get inavolisib. So the addition of this PI3 kinase inhibitor was able to prevent initial resistance to hormone therapy that you would think these patients' tumors would have. Really remarkable to see that, and it mirrors what was seen in a mouse model, which we don't see a lot. So it's very cool to think that this data, which was more than a decade before in mice, seems to have played out in patients where we might be able to really benefit patients a lot. Remember, all of these cancers recurred early, and they had evidence of mutations in PI3 kinase, which is about 40% of patients with hormone receptor positive breast cancer. If you look at the numbers here, what you can see is that the time to the cancer progressing was doubled. This hazard ratio here means that the relative improvement was 57%. So it's really, and it's early data, but it's really encouraging. They also saw, they look at overall survival, it's just too early, but there's a trend towards improvement in survival, better responses in these patients as well. But a big area that we're concerned about is side effects. And this drug has a little bit different side effects than Piqray, which has been hard for many patients to tolerate. A little less true diabetes, that's hyperglycemia, high sugar. But, they didn't enroll patients who were at big risk for diabetes. So we'll have to see. We have planned a trial actually with Laura, who's on trying to look at patients who do have high sugars and seeing if we can manage their sugar on inavolisib. So that will be quite interesting. And inavolisib is being compared directly to alpelisib, Piqray. So that will be really important also. Some patients had mouth sores, but they weren't too bad. Diarrhea wasn't very common. And importantly, rash wasn't very common, which can also be a big issue with alpelisib. So again, different population enrolled, but very exciting to see this incredible effectiveness, but also seems like really good tolerability, at least outside of the diabetes question. Very few people stopped treatment because of toxicity. So that was really encouraging. And I think, exciting to see this data. Again, because they reached their endpoint, we're really hopeful that this drug might get approved in the next year, sometime this year. And then that will give us another opportunity as well to treat our patients. As the Capitello 292 trial that Michelle outlined nicely is looking at that same population with capivasertib. So that will also be a really important combination. So we'll see what happens. There are also lots of trials that, and Joe Chien has been very involved with this in both the neoadjuvant setting, but also in the metastatic setting, looking at new oral hormone therapies in combination with a lot of targeted agents. We have a bunch of trials looking at drugs that have really big names, vepdegestrant, palazestrant, that Joe is running, and elacestrant as well. All three of these drugs are being combined with different targeted agents. So definitely have lots of opportunities at UCSF. And we have so many things to talk about, but I'm thinking that in the last little bit of time, maybe what we could talk about is, I'll have to decide, but do you need, more surgery in the axilla than a sentinel lymph node, and when not? And maybe we can briefly mention, just like without slides, datopotamab, and whether you should give immunotherapy after surgery alone. So let's see what we can get through. Michael, you're on.
All right, I'll do this pretty quickly because it's pretty straightforward, which is good and excellent. So the question of for women that have neoadjuvant chemotherapy, and then after the therapy, when they do the sentinel lymph node biopsy, and they have tumor cells in the lymph node, the kind of standard of care or guidelines suggest that we have to remove all the lymph nodes. So that's the so-called axillary lymph node dissection, which increases the risk of all sorts of complications, including lymphedema. And that's for macrometastasis, that's for micro tumors, that's for isolated tumor cells. And our group at UCSF has always thought that this is a little kind of not really going with the data that we know from all other types of breast cancer surgeries where we've de-escalated in this situation many, many times. So is it necessary? We think that it's probably not in a lot of cases and in most cases. But we still are trying to push people to do less in the armpit lymph node surgery because it's not going to benefit them very much. And especially since radiation works exceptionally well for any kind of microscopic or residual disease. And so this was a presentation at San Antonio that looked at having neoadjuvant chemotherapy, doing the sentinel lymph node biopsy, and if you found the tiniest bit of tumor cells in the lymph node, the so-called isolated tumor cells. Now, again, that would be an indication for removing all the lymph nodes, even though our group feels very strongly that's unnecessary. But this was a kind of a collected observation of multiple places around the world to kind of see what the outcomes are. And one of the reasons that people push to do the bigger surgery is that there are a number of studies that show that when you have a little bit of tumor in the sentinel node, there's a high chance, 60%, that other lymph nodes may have tumor, 37% chance there might be more tumor, 64% chance there might be tumor. So it's kind of this outcome that doesn't really tell us about what's going to happen in the future, but just immediately that, oh, well, we have to do it. We have to remove all the lymph nodes because there's other lymph nodes that have microscopic disease. But we would say that radiation will work just as well, if not better, than surgery for those patients. And so in this study, they really wanted to look at kind of real world outcomes, what happens when women have the isolated tumor cells in the lymph node, and either they do have the bigger surgery in the armpit or they don't. And you can see here, it was from all over the world, from the United States and Europe, South America, everywhere, really kind of trying to get data from all different places. And eventually they had a pretty good number of patients, about 580, that had these small amounts of tumor in the sentinel node after neoadjuvant chemotherapy. And surprisingly, which I think is really great, that 400 of them did not have the big surgery, and a little bit less than 200 had the big surgery. So as you can see, most people already kind of have that idea that you probably don't need the bigger surgery. They're just usually afraid to say it in public. Here you can see, you know, how they're detecting it. And this is a busy slide, but what's really important is this little box down here, the tumor cells detected on something called frozen section, which means that they took the sentinel node while the patient was asleep, sent it to pathology, and they checked it while they're asleep. And if they saw something, they were much more likely to get the bigger surgery. So at our institution, we've stopped doing the during surgery look because we don't think it makes any difference. But you can see, so unfortunately, that does lead to bigger surgeries. Here you can see that most of the women got radiation, whether they had the bigger surgery, all the nodes or not the nodes. So you're going to get the radiation anyway. And when you do the bigger surgery and the radiation, you're at such a high risk of the swelling in the arm. So that's why we really want to try to do less surgery if possible. And what they found is that when you did have the isolated tumor cells, you actually only had a tiny bit of tumor in other lymph nodes. So it really wasn't as worrisome as people thought. And then finally, kind of the outcomes of this, what they showed is that whether you had the bigger surgery or not, there was no difference in the recurrence in either of these. So again, this is great. It's not a randomized, perfect clinical trial, but it does show that there's really no difference whether you have axillary lymph node dissection, the bigger surgery, or you don't have it and you just have radiation when you have isolated tumor cells in a lymph node after neoadjuvant chemotherapy. So it's the strengths of this is it's the first study to really look at it. There's a large number of patients, multi-center, all sorts of settings, whether it's public, private, or community, but it is kind of shorter follow-up. It's a retrospective. It's not a randomized controlled trial, but there are some very good data here. And the conclusions are that, you know, they're saying that using the bigger surgery is probably not that important for limited amount of tumor in the sentinel node after the neoadjuvant chemotherapy. So I think that's just kind of a great thing to we're finally getting more data, and there are bigger trials that are randomized, but they're going to take forever to get the information, because the great news is that women are doing great and there aren't a lot of recurrences. So because of that, it takes longer and longer and longer to get the information. So anyway, that's what I wanted to say.
That's great. I mean, it's so important because this is all the quality of life, and we really hope that we see less and less of these big, lymphedema arms that are so awful for patients to deal with. And, if they're not going to affect the risk of recurrence, it just seems horrible to create that quality of life impact. So we're at time, but I think it just would be really helpful to hear like 2 sentences about datopotamab deruxtecan and 2 sentences about you might even be able to do 1, immunotherapy after surgery. So Joe, quick dato, and then Laura, immunotherapy.
I'll do a very long run-on sentence. So datopotamab is a new exciting antibody drug conjugate where it's linking an antibody against a protein called TROP2 to a chemotherapy called deruxtecan. And it's interesting, it's taking the antibody from Trodelvy, you may have heard of that drug, and linking it with the chemo from the drug Enhertu, and now that's called datopotamab deruxtecan. And this trial tested this new antibody drug conjugate against standard chemotherapy in patients with ER-positive, HER2-negative breast cancer who had received at least 1 or 2 prior lines of treatment in metastatic disease. And what they found was that it was better than the standard chemotherapy. And the standard chemotherapy was just options, standard options that the provider could choose, and found that it was superior. And not only was it better, but it was better tolerated. And it was better tolerated in patients who had brain metastases and patients who were on prior CDK4/6 inhibitor for a long time or a short time. So it's really exciting. This presents another option for our ER-positive patients. It's also being developed in triple-negative disease and in the early stage as well.
That was great, really interesting. And, we're learning all about the side effects, et cetera, and we'll see a lot more data on this and hopefully approval of that drug as well in the next year or so. We'll see what happens. And, we know that immunotherapy with the drug Keytruda or pembrolizumab added to standard chemo as neoadjuvant therapy for triple-negative breast cancer that's at least 2 centimeters or has a positive node has improved not only the pathologic complete response, but also the risk of recurrence, even distant recurrence after surgery, even in patients who didn't get a PCR. So one of the questions was, what if you went to surgery first and you didn't get the immunotherapy, which we're really trying to discourage internationally, really working with our surgeons to discourage that. But there was a trial presented, Laura, that you discussed. So again, short sentences.
Sure, yeah. The 1-sentence version is, if you go to surgery first for triple negative, it does not help to get immunotherapy afterwards. They randomized patients to get chemo alone or chemo plus immunotherapy, and there was no benefit at all of immunotherapy afterwards, which is all the more reason we should try to treat people before surgery to get the immunotherapy in before. The reasons for this, I think, are a longer discussion. It's possible that it needs the tumor cell around for the immunotherapy to work as well. And once you've gone to surgery, there's less tumor cells around, it doesn't work as well as the thought, potentially.
That was a great summary. And indeed, I think, there's a lot of arguments about lower risk disease, blah, blah, but indeed it was a really big trial, thousands of patients, and it didn't show a benefit. So we really do want to do treatment first, even when people feel anxious about, having this thing they can feel removed. It's so much better for patients to get treatment first. And as I mentioned, Joe Chien on the call, on the Zoom is studying this with lots of new agents in hormone receptor positive disease, which is really exciting because we haven't had good options there. And she's really looking, I think, to push the limits of what we can do there and not just accept what we've done already. And, for hormone receptor positive high risk disease, we're looking at immunotherapy. For triple negative disease, new treatments after surgery, if it doesn't all go away, where we have trials now looking at new agents, a vaccine and new antibody drug conjugates, sacituzumab after surgery. So there's a lot going on. And neoadjuvant therapy is definitely the way we want to approach this. So we've heard a lot of things today, a dizzying array of studies, and it's only a fraction of what, of course, was presented at that meeting, but we'll have a chance to talk to you more about new data from ESMO Breast, ASCO, and other important topics as we move forward. So send in your ideas to Melody, sign people up for the forum listserv. Let us know what you think about this session. Thank you to Michelle, to Michael, Joe, and Laura for taking your time after a busy day and volunteering to educate our Bay Area community. Thanks for Melody for volunteering to run this forum. Without her, this would not happen. And we'll look forward to seeing you at our next forum.
Thank you. Thank you.
Thank you. Bye.
Bye.